It's a pleasure to be here. I was really tickled to be invited. I think I probably owe that invitation to Jeremy, but I'm not sure. In any case, I couldn't possibly turn it down, so I'm really pleased to be here. I had read the papers for which Andrew was the first author, and you've heard a terrific introduction from him of these two first papers that had been published. So what I want to do, or what I think I was instructed to do, was largely raise some questions. Some come from other people or from the wiki pages, and some were things that I was uncertain of. I think some have already also been brought up already in our earlier session. But I think that that's the main object for trying to prepare for tomorrow. Some things that need to be clarified as the expert panel goes forward, and some things that might get put on a sort of the back burner for the next round of all the work that apparently lies ahead. So I'm going to try to get through mine very quickly and then have further discussion or Q&A, or mostly Q, I suppose, from all of you and from the folks on the webcast. These were two papers. One is the whole exploration of issues relating to defining research subjects, and the other was the informed consent. And so I'm just going to kind of run through some of the issues that I saw. It clearly turns this definition that's been proposed on interests, quote unquote, that might be compromised or that need to be protected in order to say that someone is a research subject. And you find what those interests are defined in different ways. One grouping has it as health, welfare, and privacy. Health seems pretty clear, privacy seems reasonably clear, welfare I'm less certain of. Another grouping has it as physical, psychological, or social injury. So it's actually kind of the reverse. It's the harms that are from which one might need to be protected rather than benefits that need to be secured. I had wondered about economic circumstances, and Andrew did indicate that in fact issues relating to a person's economic interests, financial interests, may well be something that needs to be added here. It may not fit into welfare if welfare is considered perhaps to be more well-being. And I think returning to this perhaps in the discussion tomorrow or at a later date about whether there are other such interests that need to be spelled out is worth considering. And the reason I say that is because I wasn't absolutely sure that these interests or potential harms are kind of sufficiently well or commonly understood to cover, in part, what might be thought of as secondary effects or injuries. We might worry, for instance, about information that gets out about genetics that is a risk to employment if information gets back to your employer. In the US, at least, things relating to whether you're an immigrant could now be a serious threat. So there may be some other broader questions, and I've kind of brought up a couple from the U.S. perspective, but I want to say more generally, I think we do need to be considering even more international issues. It's all well and good to think that most of this is done, or the trials are run by, and perhaps funded by, if you will, top-tier countries. But what are some of the additional questions that might arise when the potential research subjects are in fact in developing countries, very poor countries, and so forth? And then I also, it's sort of the obverse, I mean, I've said, are there other interests that need to be considered? And I think some of these international ones might fall in that category. But then, do we need some real exegesis about what are all these possible interests? And if you did that, would it suddenly get to be just too long, too unworkable? And are we better with some of these just kind of open to interpretation categories? It's somewhat similar to the issue I just raised before, whether there are still additional harms related to being a potential research subject. if in fact certain kinds of information, again, as with genetics and employment perhaps, or insurability, but if certain kinds of information about members of the participants in the cluster, whether anything about them might become somehow public knowledge, and the stigmatizing kinds of problems of STDs, mental health, any of a number of other things, does that pose a particular problem that needs to be considered that would be over and above what you might do for just standard trials or observational studies? And similarly, somebody, I think on a wiki page, raised the question of whether, if the cluster is made up of, let's say, general practitioners or teachers or other professionals, and it turns out that data collected on them sort of reveals that they have not been acting in their patients' or students' or whatever best interest, or otherwise are departing from accepted professional standards. What happens to them if that kind of information became public knowledge? Third set of questions, and this has now come up several times, and I think we're going to keep returning to it, is exactly what to do about certain so-called vulnerable populations. And there is the whole issue of children, which would go all the way through adolescence, I think. And I wanted to just sort of PS that the question about minimal risk, which may pertain for adults, may not pertain for children. The requirements about what is or isn't minimal risk may be more rigorous, and those of you who are trialists might need to comment on that. But I think children are a particular issue. You have cognitively impaired individuals who may be elderly and dementia, or have other sorts of, cognitive impairments of one sort and another. I had put here the persons who are institutionalized, that can be prisons and jails and so forth, but also people who are institutionalized, so to speak, in, say, nursing homes and so forth. So there's another class of folks to be especially concerned about. You have mentally ill patients, seriously mentally ill patients. Andrew comes from an emergency department, and others here, I believe, have been doing work in emergency issues, and so that, and people who are unconscious or otherwise in severe pain or what have you, may also raise some particular problems. But there may be other sorts of vulnerable or disadvantaged populations that we need to take into account. And again, as I said, I think some particular thoughts about international work needs to be considered there. The last, and you didn't say this, Andrew, I think in your presentation, but somewhere in one of these papers is this issue of whether, let's say you're doing cluster randomized trials and it's patient safety or quality improvement or so forth, and there's this issue of so-called novel healthcare delivery. And I wasn't so sure I quite understood what the issue was there, but I wondered whether people actually share a conceptual notion of what healthcare delivery is in this circumstance in which perhaps patients are your sort of the members of the cluster. They're not the people, they're not the physicians, but your patients. But what happens when patients become irrelevant and the care delivery is between two sets of professionals? And is there anything going on there that needs to be clarified? And then I just wondered what novel meant and whether it has a particular connotation for this application. Because who gets to say what's novel versus what's standard care, if standard care is essentially usual care or your placebo arm or what have you? And if that's going to vary across lots and lots of settings and types of professionals and so forth, then is there complication there? Okay, on to the informed consent questions. Andrew has given us the definition of passive consent and raised the issue of whether it's more or less protective of subjects' autonomy. And I think that probably needs a little more explication. But the biggest question that I had, and again, I think this came from a wiki page, is what are the regulatory issues or barriers to anything relating to passive opt-out sorts of options versus either waivers or active. And I think the regulatory issues differ across countries and across countries. And so I think that may warrant a little more exploration. Then there is this question of, suppose you don't get a response. Can people assume that if you didn't get any answer from potential subjects, that is in fact consent to participate, or do they have to regard no response to be that people don't want to be involved, or does it sort of depend? And I also wanted to raise the question of what is intended by the language that says that subjects need to adopt the study aims as their own. I am not convinced that that is as clear as it ought to be and as good an expectation on the part of subjects. So I think it needs a little exploration. But in any case, if you have something other than active consent procedures, and if this goal is important, then do these other approaches other than active consent, in fact, undermine that goal? We heard a lot about, in the earlier session, about gatekeepers, and that's essentially what I was trying to get at here. Who can provide that kind of consent? Is it the same as would be for a regular trial when consent is delegated, or is, there are surrogates, or do community elders and so forth count as providing third-party or gatekeeper consent? And I think then also the question of timing, which Andrew had already raised, is important. Two last things which don't pertain quite as much to the two papers we've heard today, or so far, but I wanted to raise them anyway. Actually, this first one probably is sort of related. It's when would you be providing information and how much information? And, are you absolutely obligated to do it, or is there just some benefit or advantage to doing it? But one of the questions that I had, because it sounded like it was an either-or situation with respect to, is it, are you an intervention arm or in a placebo arm, or say a usual care arm? But there are lots of trials that have more than two arms. And then the question arises, if you've got two intervention arms and a usual care arm, do the people who are in intervention A arm and intervention B arm, should they get information for both of those arms? Forget the usual care stuff for a moment. Because supposing that you learned that you were in the enhanced intervention B arm, you might be very happy with that. But if you're in the intervention A arm and you learn about B, you may be kind of annoyed that you didn't get included in that one. And the other one is somewhat similar. Exactly how much information should be given and when should it be provided. And then there was this question of selection bias, such that in the context of whether you're doing a passive opt-out kind of thing, that the waiver of consent is actually a preferable approach to trying to do a passive opt-out thing that kind of leaves you not knowing what did people really agree to or not. I think that was that. So thank you very much.